And I will focus on the TEER because I saw that the following lectures are on the TEER. And the patient selection will focus on two attributes, two aspects. First is the selection of the pathophysiology nature of these patients, the stage of their disease, and concentrate on some of the evidence, and then some anatomical selection criteria, of course. So the duel over the previous years, since 2018 and up to the last year, has been between the COAPT and the mitral FR population. And this divergence, this strikingly different results, the neutral result on the mitral FR and the strongly positive result on the COAPT, led to lots of hypotheses, including the proportion versus disproportion RMR hypothesis led by Paul Graeber in his paper. And, this way we try to explain, which would be the ideal patient. And, largely the very strong positive outcomes of COAPT trial actually led us to shape the guidelines that this population with an ejection fraction between 20 and 50%, with severe disproportionate MR led by the criteria of the study, would be the ones to benefit, and everybody else wouldn't benefit. But of course, that is not the whole story. We were all hoping that the reshape will be the tiebreaker. Indeed, this largely Greek study, and many of the contributors are in the room, Dr. Spargias, Dr. Chrissoheris, my cousin Elias, we led to a 505 patients cohort, and that gave a different population. So these were patients with moderate to severe mitral regurgitation, in ERO of 0.23 versus 0.40 of the COAPT and 0.31 of the mitral FR. But what was significant is this population had smaller ventricles, and I will allude to that in a minute. And we saw that it was a massively positive result with the number needed to treat for 5 and a median follow-up of 18 months. And this was largely led by reduction of the hospitalization and, of course, improvement of the quality of life of the patients. Marginally, the all-cause mortality was lost by 2 deaths or 3 deaths. We knew that the study was underpowered. This population was low risk. The control group was low risk, about half the risk of the population of the COAPT. But these endpoints have been massively reduced, as you can see from the p-values, and this was a positive study as published in the New England Journal of Medicine. Look at this population. So clearly Reshape has got the lower degree of mitral regurgitation, but the left ventricular volumes of the Reshape are same, almost similar size to the COAPT. So this is a proportionate MR, not disproportionate, but the ventricles are not that dilated compared to the mitral FR population. So possibly these patients are not in the end-stage disease. That creates a new hypothesis about who to select for application of TEER therapy, patients with secondary MR, proportionate, not very dilated LVs, but we shouldn't perhaps wait until the mitral regurgitation becomes that severe, risking this way for the patients to get to the end stage of the disease, because we all know that the time course between moderate to severe and severe mitral regurgitation is largely unpredictable. A few patients during this course, which may be a few weeks, a few months, or a couple of years, may end up in an irreversible damage, and then it might be too late or futile, like the mitral FR population. So these are the graphs that shows the Reshape HF2 is proportionate versus COAPT, but definitely the volumes are lower. Now, what about the anatomic selection criteria? Clearly, a central mitral regurgitation with no calcium, no coaptation gaps, good enough leaflet, like a leaflet length above 10 millimeters, no calcium, relatively focal versus a restricted anatomy with short posterior leaflet, calcium, small mitral valve area, presence of a ring, or even too extended damage on the mitral valve, like a Barlow's disease, are the two ends of the spectrum. So we know that this patient can be treated very, very reliably. The EXPAND G4 and our personal experience, which is now published, showed that these patients should achieve +1 or less residual MR in over 98% of the patients. This is the green light. versus the red light. So this is the calcific restricted mitral valve with a short or even absent posterior leaflet. And these patients have got higher chances of having stenosis or inadequate reduction or even SLD. Clearly, this is the red light population and we should steer away. Perhaps this is the population that should be treated with TMVR. And the yellow light is something in between with borderline areas, borderline length posterior leaflet, tending heights, or multiple jets, commissural jets, and large widths of prolapse. These patients can be treated. The Expangi-4 showed reasonable results, but we have to be careful. If you put a device in the middle of the valve and have not a good enough reduction, then these patients will not do well, and then you're left with a device in the middle to treat later on, and that is another additional problem. So the key clinical messages is the new evidence of reshape, and I'm really curious to see the new guidelines will incorporate the reshape data. They should, in my opinion. Reinforces that the MR is a therapeutic target, not a bystander, validates the early and proactive intervention, and actually broadens our treatment scope beyond the quad patient. So in my humble opinion, we no longer need to debate whether treating MR helps, but we need to focus on who we're missing. Thank you very much for your attention, and I'm open to questions.
Thank you, Dr. Ninios. It was a very pragmatic introduction of this topic. Other comments?
Congratulations, Vlad. It's a beautiful overview. Indeed, what we need to consider is who we are missing and which patients actually tend to even go for surgery still in these days for just functional MR. That we need to discuss and explain to the patients that there is an alternative option that's significantly safer and very effective.
I agree, and I don't want to sound too polarized in that, but you know, if you wait long enough for the patient to get to an end-stage situation, then the therapy is futile. Early intervention helps. Early intervention means better outcomes because these patients will have less dilated annuli, less gaps, less stenting, and then, you know, putting one device in the middle will actually do the trick and you'll have a wonderful result. And we've seen that this is meaningful, is actually prognostically meaningful. Whereas surgery right now is not even supported by the guidelines unless there's a concomitant revascularization. So I really see if there is no argument in that.
Very good.
Okay, any comment from Dr. Shuvy? Dr. Shuvy?
Yeah, good morning and thank you very much for inviting me. Excellent presentation, Vlasis. And I think it is important to emphasize also your point of early intervention. And it's very important also to limit the time for allowing medical therapy to kick in. I remember that you waited years for up titration of the medical therapy of heart failure population, but we know now that we should wait for 3 to 4 months from the diagnosis of heart failure until up titration of the medical therapy, and then reassess the patient. Patients with severe MR who are still symptomatic should go for early TEER and not waiting for additional time, because then the patient deteriorates, and as Vlad said, this therapy might be futile. Another important topic is the ability to up-titrate the medical therapy after TEER. We know that TEER also allows us to increase the dosage of heart failure medications and get better outcomes. So this is another point that should be discussed with the heart failure physicians to allow patients to get the best medical therapy after treated with TEER.
Vlasis, I will take the opportunity to make a comment concerning the severity of mitral regurgitation, the functional MR, is not always what it is considered to be at rest. Usually there is a dynamic component. And this is a very, very prevalent phenomenon on functional MR, and probably the data from the reshape to justifying the necessity not to be restricted to the very high severity of MR, but also we should take into account the less impressive severity, which probability-wise implies dynamicity. And moreover, I'm concerned about the restriction of the anatomy of the LV for the end-diastolic volume. In MR, the key component for the outcome concerning the functionality of the LV is the end-systolic volume. And we should be aware that the end-systolic volume is the most important component to justify what is the underlying contractility reserve of the LV. So which are the relevant data from the RESHAPE-2? Have you any comment about it?
I mean, these are excellent points and show the versatility of the disease process and the unpredictability. Also, the fact that loading conditions and afterload situations can alter the phenotype. Let's not forget that exercise testing, also exercise echocardiography, has been validated in some of these patient subsets and actually can give additional information. Unfortunately, RESHAPE doesn't have a dissection of the echo data yet, so we don't know specific subgroup of patients and analysis, and whether we may come up with some conclusions for specific volume subsets like LV volume. But what is very clear in this is a low risk population with relatively small LVs, quad-like, and less burden of mitral regurgitation, at least on presentation of this and assessment and recruitment of this population. And we still saw significant benefit. So clearly, there is a lot to learn from this. And I don't know what your opinion is in the room, but I think the guidelines should incorporate this population. It's a randomized study with positive outcomes, and I think we should expand the treatment for this population.
Okay, thank you. Any comments for the audience? Dr. Koutsogiannis.
Thank you, Dr. Ninios.
Button.
Do you think that we are moving from the degree of the MR to the degree of the reverse remodeling viability to set some cutoff points of left ventricle to reject some patients or to accept some other patients? Or we have to have some cutoff points of the left ventricle to accept some patients?
Well, that's a very good question. I don't think we have good enough data to support remodeling following TEER. There is some data on the quad that there is some degree of remodeling, but generally TEER is not considered as a remodeling method. I mean, there are other devices that are being evaluated as we speak for LV remodeling, like the Carillon device and the Empower trial, and also the IQSINS device with the CoreSINS trial that they both run in Greece and other countries. But the problem is that there is a clear signal that if you exceed a left ventricular end-diastolic volume around 200 mils, for example, give or take a little bit, and if you go to 250, which is the quad, then there is a zone there that beyond that you may not get benefit. I mean, you don't probably harm the patient, and I think we should individualize. We've all done patients with LVs above LV diastolic dimensions around 7.8 or even 8 centimeters. Patient felt better, but clearly prognostic benefit is not there, at least with the data that we have. And I think we should be, the message, I think it's clear, treat these patients earlier. Don't wait too long, because if they dilate, they may not come back.
Okay, Dr. Pavlidis.
Yeah, just a comment on following the Dr. Athanassopoulos' comment. Well, based on the RESHAPE heart failure, as a general rule, we cannot really recommend, and it is not recommended, that people with moderate MR and heart failure should be treated. So yes, as you have elaborated already, we have to be very careful in selecting these people, the patients. Regarding the end systolic diameter, you're correct, George. In a recent review, actually, by Eric Nishimura, who was the main author for the valvular guidelines in the US. He suggested that the end systolic diameter should be 45 and above so they dropped it even less than 50 that used to be. So it's really, until we have the analysis of the reshape heart failure echo data and combine this with the COAPT, we don't really have a real, I mean, the experience of the individual center is very important in selecting these people. But as a general rule, we cannot really recommend, at least it's not recommended to treat these people with moderate MR and heart failure. That's at least, I don't know what, Vlasis, do you think about as a general rule? Because if this thing goes out, every moderate MR would be treated. And that would
I
not be a
totally
good
agree.
idea.
That's why I totally agree. And, that's why I said that we need to wait and see if this is adjudicated and incorporated in the upcoming guidelines. I think the message is softer, is that, if you have a patient with an ERO of 20, 25, you say, okay, patient has got moderate MR, not yet ready or appropriate to treat with TEER. Let's review the patient earlier. Don't wait another year before you review, because by that time, patient might have decompensated. The time course is unpredictable, and we've all had these experiences. Patients go in with decompensated heart failure, they get into renal trouble, pulmonary edema, and sometimes then it becomes futile. So watchful waiting is something that should be implemented, but actually be implemented, and also optimize medical therapy in the meantime, if possible.
Yeah, one of the major problems remains the fact that we don't really know what is the optimal medical therapy, and what is the time waiting before you say, okay, I've done everything I can, and then I reassess. That's something in the new guidelines should probably be considered.
Well, it's a very interesting topic, because we have to take into account also the underlying substrate, the mechanism. It's a different mechanism if you have a dilated atrium with dilated annulus comparison to a dysfunctioning papillary muscle due to an extensive inferior MI. So it's a very complicated underlying pathophysiology. Anyway.
One last comment from an echocardiographic standpoint. I think focusing on the ERO as a single number to assess MR severity may be inadequate. We need to try and also incorporate regression fraction in our thought process, because I think that's important as well.
Okay, perfect. So thank you so much, and we have to proceed to the next